Hi, everyone. Welcome to week 5 of Issues and Trends in Health Systems. This week we're talking about access to care, and the key topics are who are the uninsured, what are some of the problems that arise from being uninsured, and we're going to talk briefly about Medicaid expansion and health insurance exchanges and healthcare workforce challenges. These are all components of the access question. So, as people are trying to get access to healthcare, they need insurance simply because healthcare is so costly. If you're wealthy, you don't need insurance. Now we know, of course, as a result of the Affordable Care Act, there's an insurance requirement in our country, but there are exceptions to that requirement. There are about 8 exceptions. And if you don't want insurance, you can simply pay a penalty. So no one is really being forced to buy insurance. Now, there's debate about what force means, what coercion means, and of course, as you reach a certain level of penalty, essentially essentially government is forcing you to do something if the penalty is so great that the penalty would cause some harm to you. But at least starting out early in the process, the penalty is only $95, and so it's really not would not be that much harm to someone who could actually afford to purchase insurance. Now, the exceptions actually help people who are extremely poor, so that if you're unable to afford health insurance, you don't have to buy it and you don't have to adhere to the what's being called the individual mandate to purchase insurance, so you're not included. But in general, when people want to access health care, they're going to need to buy insurance because they can't afford it. Now, because health insurance itself is so expensive, many people go without insurance. Many people cannot buy it, right? So they can't afford health care and they can't afford health insurance. So they're put in a tremendous bind. This is particularly challenging to people who have children because there are health care requirements for children in our school system, right? You have to get immunized and so on. And sometimes kids need physicals outside of, sorry, there's not a clinic at the school, so parents have to find a way to pay for that, and so on. And kids tend to get sick, and so on. So most parents really do want insurance for their children. Now, on the other hand, single adults may make a conscious choice not to buy insurance, either because they have money to pay for their health care or because they just, you know, don't like health insurance. Some people don't like the idea of getting Medicaid, even though they're eligible for Medicaid. If you look at Medicaid enrollment rates throughout the country, some parts of the country just have less people enrolling in Medicaid because they don't like being on government assistance. Oklahoma, for example, has substantially less people enrolling in Medicaid, even though they have a substantial number of people who are eligible for it, compared to a state like Maryland, where people are okay with seeking government assistance. So culture, perceptions, viewpoints of how you live in this world matter too when it comes to who gets insurance and who doesn't. Um, so these are so you need to get insurance to access the healthcare system. Then when you have the insurance, you still need to be able to take it somewhere and have someone actually accept it, right? So if you go to a physician or a nurse practitioner or a physician assistant and they tell you, well, we only take 3 different types of insurance, and you don't have any of those 3, then you're not going to get care from them. And they can legally do that. There is no duty to provide health care to anyone in this country. Health professionals do not have a duty to provide care. Now, what they do have is a requirement to stabilize people in emergencies when you come to an emergency room in a hospital that accepts Medicare payments. And so that comes from a law called the Emergency Medical Treatment and Labor Act, also known as EMTALA. So when you have an emergency, pretty much anywhere in the United States, and you go into any major hospital, community hospital, so on, most of those hospitals accept Medicare, and they will see you. So they have a duty to at least assess you and determine whether you have an emergency, and if you have an emergency, they have to actually stabilize you. So that's really the only situation where providers have to provide some care. Otherwise, if you don't have the insurance that they accept, or okay. So who are the uninsured? The uninsured are primarily people who are low income, who are mainly working people. Um, Now that we are engaged to some degree in an immigration debate in this country, I'm not sure how far they will go given all the other things that are occupying government now. But we were really on the path to doing something about immigration there for a while, and we may come back to it before Obama's out of office. If not, then it will come up again because it's just a pressing issue for our country. How do we deal with people who are immigrating to this country, and definitely how do we deal with people who are illegal immigrants? Well, turns out that illegal immigrants don't make up the bulk of people who are uninsured. Some people perceive them to be the majority of the uninsured, but that's not true. Most of the insured are citizens of the country, and they're low-income people who are working. But there are a substantial number of people who are undocumented immigrants who are uninsured, and we think that accounts for roughly about 10 million. So it's not a small number. We think that accounts for about roughly 10 million of the people who are insured. So, or sorry, uninsured. So when you hear figures on the number of uninsured people in the country, you should always discount that by about 10 million, because usually journalists, public health officials, politicians, and so on, they usually quote numbers that include illegal immigrants, which really doesn't make sense because we're not going to really develop any policies to insure illegal immigrants, with the exception of some parts of the country that may have the wealth to do that. Some states may have the wealth to do that. DC takes care of undocumented immigrants pretty well. San Francisco does, and so on. But most of the country is not going to really do much for illegal immigrants when it comes to healthcare, and they're not going to um, create policy around providing health care to illegal immigrants. Now, on the other hand, illegal immigrants do receive care at emergency rooms. So, as I mentioned a couple of minutes ago, EMTALA exists, this Emergency Medical Treatment and Labor Act. That law actually has nothing to do with citizenship. So, regardless of who you are, if you're in our country and you have an emergency, someone shoots you, you can go into the ER and get stabilized. So you can receive treatment that will stabilize your problem, and then from there, the hospital can decide if they want to transfer you somewhere else if you lack insurance, for example. Hospitals tend not to call immigration officials. So if you're an undocumented immigrant and you come to the hospital and they treat you and you don't have a social security number, you don't have insurance, they're not really going to spend a lot of their time trying to figure out if you're legal or not. That's just not what hospitals do. It kind of goes beyond. It's really a bit outside the ethics of most health professions. They are not police. They're not law enforcement. But there are times when they need to act like that. But usually in the immigration setting, or for that particular issue, they tend not to report people, because you can imagine if that they spent their time doing that, then people would be wary of coming to the hospital because they would think that the hospital officials are going to deport them, and that would basically leave some people dying in the street because they were afraid to go to the hospital. And just morally, that's not where our country is currently, luckily. Okay, so let's take a brief look at some charts from the Kaiser Family Foundation. They have a lot of great charts on uninsured. They are very concerned about this issue. It's one of their uh, main main concerns, main focus areas. And so there's lots of data that you can find on kff.org, kaiserfamilyfoundation.org. If you're writing a paper that has something to do with the uninsured or low-income people or so on, or really any other major health policy, health system issue, Kaiser probably has some information that's going to be useful for you. So here you can see just what I was saying, that if you look at the white boxes, the white boxes represent people who are uninsured, and so as you go up in income, the white box gets smaller, right? Because less people are uninsured, right? So that should be pretty clear to you that because we live in a capitalist system, insurance and services cost money, insurance costs money, so people with more money are going to be able to access insurance and they're more likely to be covered. Now, at the same time, most of our policies are geared, or at least government policies are geared towards mainly covering people who don't have money. So you'll see an increase as you go down the income level in the number of people who have Medicaid. You'll also see a decrease in the number of people who have employer-sponsored insurance based on income. Why? Because they don't have jobs, and so employment is essential here. So how do you get employed? Well, you need skills. There are a lot of people in our country who lack marketable skills, despite the fact that they go through 10 or 12 years of education. 12 years is what most people should receive, but some people drop out early. So they may go through 10 or 12 years of education, maybe a little less for some. And they don't have any marketable skills. So they get out there in the economy and there's nothing for them, right? Our economy is extremely competitive. It's becoming more and more competitive every day, as all of you know. And so uh, getting access to resources through employment can be quite difficult. Starting your own business is also quite difficult. So, most of those individuals are not going to go out and start their own business. So, what do people do? People just kind of survive any way they can. They take odd and end jobs. Some people turn to illegal activity, unfortunately, because they really have no other option. They have nothing else they can do. And the system has really failed that individual. And as adults, they have to find a way to turn things around because as kids, they may have just faced so much adversity that they really have been sort of set up to fail in life. And so these individuals are going to be uninsured. There's no surprise there, and there's also no surprise that there are racial and ethnic correlations between poverty in our country. We have a history of discrimination in our racial ethnic discrimination in our country. We also have other types of discrimination that have occurred, gender, sexual orientation, and so on. Each country has its own unique history with regards to discriminating against certain groups, whether it's based on religion, your physical appearance, or something else. And those differences will track when it comes to will track with healthcare. And in this case, if I put up a chart on race and ethnicity, you'd see that more minorities, particularly Hispanics and African Americans, and American Indians, are uninsured. You'll see that's less of an issue for Asian Americans, who tend to be have higher levels of insurance. And of course, within those groups, there are subgroups that actually are better off than others. So if you look at Cuban Americans, you'll see that they would be more likely to be insured than Mexican Americans on average. If you look at Asian Americans, certain groups, Japanese Americans are more likely to be insured than Laotian Americans. If you look within white Americans, you'll see that people from Eastern European countries may be less likely to be insured, especially recent immigrants, than people who are native, white Americans in this country who are, white Anglo-Saxon Protestants, for lack of a better term, right? So there's a lot of variation within those groups. You can't really just say, well, based on race, we know that people are going to be less insured or more insured, but we know that our history of our country is impacting these disparities, and we see these disparities slowly going away, and the ACA will actually decrease some of those disparities that currently exist in our nation's healthcare system. Source of care, I'm sorry. If you don't have a usual source of care, then that means no one's really checking on you, no one's really aware of your healthcare status, so that if you have some major problem, you're probably going to end up in the emergency room, and you're going to cost a lot of money. Emergency rooms are especially many emergency rooms that serve lower income populations are really having a hard time surviving because of uncompensated care, because of the amount of money they have to spend caring for people who don't have insurance. So when you don't have a usual source of care, you just run up the cost for the emergency room, because that's where you're going to end up, because you don't have anyone taking care of your ongoing medical needs. People without insurance postpone seeking care. As I'm saying here, they go without necessary care. So people may avoid People may go without their medications. People may go without a particular medical procedure because they have no money for it. They can't access any insurance. They can't qualify for Medicaid and so on. They may and of course they may not be able to afford their prescription. So those are some of the problems that arise. I gave you one reading that pointed out that about 27,000 people die each year because of lack of insurance, and that definitely happens. So it's a real problem, and it's something that as a nation we really need to address. And I think most politicians would agree with most of these facts, at least the numbers, and what lack of insurance can do for society. The question is just really how do you go about addressing this? What is the role of government? How much of the solution should come from government, and how much should really come from the private sector? Or, well, when I say private sector, I mean not-for-profits and for-profits. So, how much of this should be taken care of by charitable organizations? How much of this should be taken care of by industry, finding ways to offer options to people of all different income levels. Well, you know, the general consensus among Democrats is that, well, hey, industry has had an opportunity to market, has had plenty of opportunities to provide options to the uninsured, and all we have is a growing number of uninsured people. Why? Because they actually are not. They don't. They're sort of. There's a market failure. They really don't fit into what the market's looking for. They don't have much money, right? So they can't really pay their premium on an ongoing basis. Many of them have complex health needs that insurers really don't want to cover, especially when a person has very little money to pay a co-payment or co-insurance and so on. So general consensus is that, well, you know, the market's had an opportunity and it doesn't work. On the other hand, on the Republican side, you know, I think Republicans would argue that the market has not had enough opportunities. Government hasn't helped the market operate appropriately in this arena. Government could incentivize the market more to help them deal with some of these situations. And that in some cases we may be sort of aiding and abetting this problem by helping people who are able-bodied not really get back on their feet and find a way to take care of this problem themselves. So there's some personal responsibility here that people have for finding a way to get out of their problems and finding a way to take care of themselves. You know, for example, if you take someone who's addicted to drugs or has a problem overeating or so on, you know, a more conservative stance on that individual might be, well, hey, they're making a choice and they should try to make better choices in life. So, especially if they know they have very little money, so they don't end up harming themselves, and so they don't end up in the emergency room running up costs and so on. And they should work hard to get back on track so that they can get some insurance that will take care of them. So these are some of the general arguments that you hear from both camps, and you know, depending on, you know, what issue you're thinking about, what particular demographic group you're trying to address, you may need more of one solution or less of the other, or vice versa, right? So, but that's the sort of general dichotomy we have going on in our country with regards to how you deal with the problem of the uninsured. Clearly, providing healthcare coverage is costly, but it may actually provide savings in the long run if people become more productive members of the economy and they stop depending on whatever subsidies or assistance government is offering. The question is, do they, right? So many people don't get off of these programs, and they continue to be chronically dependent on government assistance. So that's where a more conservative stance is, well, we need to pull back some, right? So, you know, the issues are quite complex, but those are the general perceptions of this problem. All right. Okay, so what's the ACA doing? It's expanding insurance options for this group of individuals. So, if you look at Medicaid eligibility throughout the country, it varies quite a bit. Well, the ACA is trying to actually set a higher standard for Medicaid eligibility that's actually higher than what you see here. So you see the states in white are at 100% federal poverty level or greater. The ACA is pushing that up to about 139% of the federal poverty level. And you can see the federal poverty level for an individual is about $11,000, so not much money. Some of you may be shocked by that number if you haven't seen it before, but we're talking about poor people. We're talking about people who are working um, um, minimum wage jobs or perhaps even getting less than that because, of course, they're getting taxed to a certain degree. So not much money at all for a family of four. Believe it or not, $23,000 is the federal poverty level. So there are some states that set the eligibility level for Medicaid at below 50% of this federal poverty level. So you would need to be bringing in around about 6,000 for an individual in Texas, or as a family of four, you would need to be bringing in about $11,000 to $12,000 in Texas, Mississippi, Alabama, and so on, Pennsylvania. So they just gives you some sense of, hey, how would anyone uh, survive? I mean, why would anyone be making so little money? People should be working to earn much more money than that. In these states, particularly in the southern states, they are not really trying to encourage people to uh, uh, accept these kind of benefits, these kind of entitlement programs. So they're really trying to push people away from them. Most people should not want to earn less than 50% of the federal poverty level because it's going to be really hard for them to survive off of that. And that's the philosophy behind the states that set the rate so low, is that, well, you're gonna have a hard time surviving, and why would you want to be in this situation? So you're only going to use this when you become unemployed, or when you're really down and out, and then you're really going to work hard to probably try to turn things around. That's the general philosophy. Whether that works or not is sort of up for debate and for research, but that's the general idea. Whereas other states that set the rate much higher say, hey, we should be more generous, get allow people to at the 100% federal poverty level or higher to access this benefit so that they can stay healthy, survive in our economy, and keep going. And they're hoping that they will also, those people will also want to earn money, and that they'll keep trying to be productive. And if they set a higher bar, that they'll catch them before they really get completely down and out. Less than 50% of federal poverty level is pretty bad, and most people don't want to be in that situation. So they don't. Instead of waiting on people to get that bad, they want to catch them a little earlier and then try to turn them around. All right. The ACA is addressing this variability by setting a basic standard for states, and states can always go above that level by using their own state funds, and they can also work with the Centers for Medicare and Medicaid Services if there is funding available to potentially raise the level beyond what the federal government is setting as a minimum limit, a minimum eligibility requirement. States could work with the federal government to actually have the federal government pay part of the expansion beyond what the minimum standard is too, if there's funds available. As you know, we are in a point where the nation is really suffering financially, so that's unlikely to be the case in this current environment. But in the past, there have been situations where states have really gone beyond, far beyond the minimum eligibility level, and really insured many more people than the federal government anticipated that all states up to a higher standard. Okay, and as I said before, we really want to address this group of people who are adults who have no children, and they're kind of out there not doing so well, and lack of insurance is really not helping them. And a number of these people are homeless. Not the bulk of them. Most of them actually are in homes. They're just working poor people, just trying to survive. I'm sure all of you know someone like that, either in your family or friends or so on. But about 300,000 of them are homeless, and really are in dire situations. And definitely, if you've been in any major city, you've seen individuals who are homeless who don't have any insurance, they don't have anywhere to live, and so on. So those are individuals who are really being harmed tremendously by this lack of insurance, and by Medicaid not covering people who don't have children. Typically, Medicare covers children, and they cover families, and they cover pregnant women. So the idea is that you are somehow attached to children, and we want to take care of you as the adults who have these children around, or the mother who's giving birth. And of course, you have to meet the eligibility requirements, the income requirements for Medicaid in order to actually qualify. So typically, Medicaid programs do not cover adults without dependent children. And there are some exceptions to that. There are a few states out there that do already, but most do not. To receive, and that's going to get the majority of the uninsured. But as you see, there are some people in that 400% plus level, and there are also some people who will qualify who will not enroll that we're going to miss. So we're going to end up with a number of people who are still uninsured. So if you look here in this diagram, without health reform, we have about 20% of the people in our country who are uninsured. And with health reform, we reduce that down to about 9%. So we've increased the number of people on Medicaid. We've increased the number of people who have some insurance that's for individuals, or perhaps geared towards small businesses through these health insurance exchanges, or individual health insurance through the health insurance exchanges. And then we still have employer-sponsored insurance. As you might notice, employer-sponsored insurance goes down without health reform. Why is that? That's because some employers, especially smaller employers, are going to adjust their worker mixture. So they're going to change the number of people who are part-time and full-time, so that they don't have to adhere to the Affordable Care Act's employer mandate. There's actually a mandate that employers offer insurance or pay a penalty for the workers that go out and use one of these government programs to get insurance. And so some insurers would prefer to do that, but that mandate only applies to employers of a certain level, so with a certain number of workers. So if you're below that level of workers, then you're just going to not provide your workers with insurance if you haven't been doing it before. So those workers are going to go off and get insurance. Many employers who have already been providing it will sort of change up their mixture of workers and stop offering insurance and just pay the penalty instead. So that will decrease the number of employers who actually offer insurance. And we think that number will probably continue to go down over time, because we'll probably end up seeing more employers deciding that a penalty that has fixed costs is better than health insurance, which has a variable cost. And so, as they look at their budgets, they're going to say, well, we'd rather pay this penalty that we can predict and probably just pay for up front, pay on our taxes, than worry about variations in premium amounts moving forward, just because the cost of healthcare going up over time, right? So you can imagine that some insurers are going to go down that route. The government is working hard to try to stop that from happening, but it's sort of inevitable. They're in the business of making money, and if they can cut their costs, they're going to. All right. All right. Now, finally, workforce. As I mentioned before, although people are going to have insurance, they're going to have Medicaid. Some people are going to have insurance through the health insurance exchange, so they're going to have this private health plan. They will not necessarily be able to get health care. And why is that? That's because many doctors will not accept Medicaid, even primary care doctors. There are some primary care doctors out there who do not take Medicaid. And why is that? Because there's a doctor shortage. So when there's a shortage, people can pick and choose, right? So if we have a shortage of doctors out there, then doctors can decide who they're going to accept. They already know that they are in high demand. And as you see here, the demand is continuing to go up over time. And the demand is outstripping the supply of docs that we have. And you see the same thing going on for nurses, as I have here in the graph on the right. And this is also happening in a number of other fields of healthcare. We just are not producing enough healthcare workers for the demands that our population has. Sorry, and this is particularly a problem as our population continues to age. Right, so we know that baby boomers are getting older every day, and their healthcare needs will increase as they age, and so we need people to be available to take care of them. We have a shortage of geriatricians in our country. Why? Because they don't get paid very well, so we don't see a lot of doctors going into that specialty. In fact, geriatrics is one of the specialties where if you do a fellowship in geriatrics, you're actually losing money because you'd be earning more money outside of the fellowship than you're going to earn after you do the fellowship, right? So, what kind of sense does that make? And only people who are really passionate about the field are going to actually do a fellowship in geriatrics, and that's not a lot of people, unfortunately. So the money just isn't there in these fields. So the Affordable Care Act is also trying to offer incentives for physicians to accept Medicaid. So at least I think, if I remember correctly, first couple of years, there, if you for primary care docs accepting Medicaid reimbursement, they'll actually be able to get the Medicare level of reimbursement. So basically, they'll be able to get more money than they typically can when they see a Medicaid patient. So that's government trying to provide some additional funds, some incentives to get people to see these Medicaid patients and to go into primary care because they're trying to put a little more money into it. There's also something called the National Health Service Corps, where the federal government will pay back some of your loans. So you can imagine if medical school and if some of the other health professional schools were free, then we might see more doctors going into primary care because the $150,000 or $200,000 that they earn would not seem like so little money compared to their colleagues who are earning, $300,000 and up. So now many of you may say, "Hey, that $150,000 is a lot of money," but given the loans and given the how people compare themselves to their peers, it doesn't seem like a lot of money to many physicians, right? I agree with you. I'm from Arkansas. $100,000 to me is a huge amount of money, and I'm sure those of you who are from smaller rural, especially those from rural areas of the country, have that feeling too, because you know how far that kind of money can go in those small areas. But when you're living in major urban areas, 100,000 is sort of just not a lot of money anymore, and it's sort of considered to be sort of a basic higher middle income salary, even though you're in a small percentage of people in the country who actually earn that amount of money. I think you're in the top 5 or 6% of people in the country when you earn over $100,000. So although it doesn't seem like, although it may seem like a lot of money to some of you, it's not to doctors. And so when if loans are paid for in medical school or other health professional schools, then docs might be more willing to go into primary care fields because they wouldn't feel this great deficit between them and their peers. So the federal government is actually paying back some of those loans and paying even more than it used to pay through something called the National Health Service Corps. They also pay back loans for nurse practitioners and some other health providers that are considered primary care health providers. So that's one way of incentivizing people to go into this field by increasing reimbursement and also by paying back some of their loans, right? So there are components of the Affordable Care Act that's trying to stimulate more people to go into these fields and trying to lower this shortage. But it takes time to train these professionals, and it takes a long time to catch up. And we already have big deficits that we're sort of chasing. So we're chasing that demand. We're chasing those existing shortages. And as you see down here in the left, if you look at the primary care health professional shortage areas in the country, you'll see that there appear to be more shortage areas than there are areas where we have adequate primary care coverage. So the areas where we have adequate coverage are mainly major urban areas like DC. We have a lot of primary care docs in DC. It's still hard to get an appointment, but we do have a lot of docs here. And if you try to come to DC as a primary care doc and get a job, you'll find it's actually quite difficult to get a job because there's so many docs per capita already in this area. And you see that in some other parts of the country. So, meanwhile, there are other parts of the country that really do lack providers, and this is primarily the case in rural areas of the country where a lot of doctors just don't want to live. And so this remains an ongoing challenge for us. So despite having the insurance and despite all these efforts to get people insured and all of this money, billions of dollars, going into providing insurance for people who are low income or working poor or even lower middle income people, as we talked about, there's still this barrier of actually finding someone who's going to take the insurance and getting people to go into primary care so that we are able to make sure that these individuals who are newly insured actually have a primary care doc, have a usual source of care, and have someone who's working to improve their care so that they don't end up just coming to the ER every time they need care. All right. So I look forward to your comments and your initial posts and your comments this week. And as always, let me know if you have any questions about what I presented here or the reading for this week. All right, now I look forward to reviewing your op-eds that you submit by Tuesday of next week. As a reminder, written assignments are due at the end of the week, so you just need to turn that in by Tuesday Tuesday by 11 before 11:59 next week. All right. So again, let me know if you have any questions, and I look